Thank you very much once again. So I'll also be doing a case presentation, and mine is also quite brief, just like Dr. Twahir's. This was a case that we actually managed together, both of us, me and Dr. Twahir, at the MP Shah Hospital. So this was a 60-year-old male patient. He was transplanted in June 2019. He had undergone a related living donor kidney transplant. He had a background of type 2 diabetes and systemic arterial hypertension. I saw him in February, uh, whereby he was on mycophenolate mofetil 500 milligrams twice daily, tacrolimus 0.5 milligrams twice daily, prednisolone 7.5 milligrams once daily, nifedipine for his blood pressure, and carvedilol. And for his blood sugars, he was on insulin glargine 13 units and insulin aspart 10, 10, and 6. And he was on a combination of metformin, linagliptin 2.5 per thousand twice a day. His serum creatinine in January 2020 was 100 micromoles per liter, and he had progressively rising creatinines. A kidney biopsy was performed, and it confirmed acute antibody-mediated rejection. So he was admitted and started on intravenous methylprednisolone, 500 milligrams once daily for 3 days, and then subsequently oral prednisolone. He underwent plasma exchange. He received 6 doses, and it was alternating with intravenous immunoglobulin. Um, I know that there's divided schools of thought about the use of IVIG when it comes to antibody-mediated rejection, and I am a proponent of the IVIG because of the fact that after every plasma exchange, remember that you tend to also lose out your normal and your protective immunoglobulins. There's always a rebound of the immunoglobulins as well. So for these two reasons, I am a proponent of giving the IVIG after every plasma exchange. His mycophenolate mofetil was increased to 1 gram BD, and we started targeting higher trough tacrolimus levels. And the patient was also given rituximab at the end of the plasma exchange. So these were his renal functions. We started the therapy in April because there's quite a bit of a cost constraint when it comes to treatment of antibody-mediated rejection with plasma exchange and intravenous immunoglobulins together with rituximab. The total cost normally comes to between 1.2 million Kenyan shillings to 1.5 million Kenyan shillings. As you can see that his serum creatinine basically peaked on the 4th day, and then subsequently came down by the 17th of April when the patient was basically being discharged. His serum creatinine was 148 on 17th of April. The patient was stable during the treatment. He tolerated the plasma exchange and the IVIG quite well, as well as the rituximab. His FK level or the tacrolimus level prior to discharge was 11.1. His TAC level was reduced. His tacrolimus dose was reduced. He was given IV rituximab 500 milligrams after the completion of the plaque. And as I mentioned that on 17th of April when he was being discharged, his creatinine was 148 micromoles per liter. These were his discharge medications, tacrolimus, mycophenolate mofetil. He was now on the tapering down dose of prednisolone. We started on the valganciclovir prophylactic dose, Septrin, because of the fact that we were doing plasma exchange, IVIG, and rituximab, and high-dose steroids. And these other medications basically remain the same. He was readmitted after 2 weeks and got the second dose of rituximab. He was stable during the infusion, and at that time his spread was now at 20 milligrams and had been tolerating the anti-rejection meds quite well. He was on follow-up as an outpatient, but subsequently developed persistent diarrhea. Stool infections and stool analysis and markers of infection were all normal, and we did this quite a number of times. Because of the diarrhea and the fact that he had just had Plex and IVIG with rituximab, we always worry about cytomegalovirus colitis, and we did a cytomegalovirus PCR, and it was negative. So we changed his mycophenolate mofetil to mycophenolate sodium, because it has been proposed that sometimes mycophenolate mofetil can cause GI symptoms. However, despite the fact that we changed to mycophenolate sodium, the patient still had persistent diarrhea. His serum creatinine, because he was hydrating himself well, was 127 micromoles per liter. So we suspected that most likely it was the mycophenolate. I mean, whether it is a mofetil or the sodium, remember that the cause of the diarrhea is of the active drug binding onto the enterocyte and causing a secretory form of a diarrhea. That is the pathogenesis of mycophenolate-associated diarrhea. So what would be the way forward? Now, would we change the mycophenolate and put him on azathioprine? Remember that this patient has just recovered from an antibody-mediated rejection, and that would not be the most optimum thing to do. Or should we remove the mycophenolate and put him on evorolimus? We don't have much data in terms of evorolimus post rejection. Evorolimus has become quite used, and in terms of as your startup therapy post a transplant. And in India, basically almost all the patients who come back from India are actually on everolimus, tacrolimus, and prednisolone. So what we decided to do was that we decided to stop the mycophenolate sodium. We started him on everolimus 0.5 milligrams twice a day. As we know that we tend to get quite a bit of a challenge when it comes to monitoring of our levels of everolimus. So he was both on everolimus and tacrolimus, and we were targeting a combined target of levels of 10. His serum creatinine, when the last time I saw him was on 27th of August, because of that he's been on follow-up by Dr. Twahir. His current serum creatinine was 137, and the GI symptoms resolved completely. So his baseline, I mean, his creatinine did not change much after we changed him from the mycophenolate. And that was our main worry, was that would he get a recurrence of the rejection, because we are going to a therapy which we don't know much about in terms of post-rejection. So his his creatinine remains stable, renal function remains stable, and his symptoms actually resolved completely. So I'll stop there and
thank you, Dr. Bagha, for that. So I'm not seeing any more questions yet, but I have a question for you. Have you encountered poor surgical healing after everolimus treatment in these patients who are immediately started on everolimus from the beginning?
Yeah, so this is one of the fears that we have because of the mechanism of action of the mTOR inhibitors, is that they cause poor wound healing. And the center where I did my fellowship in was in South Africa, and they actually did. They were part of the multi-center trial looking at sirolimus, and they found that there was quite a bit of challenge in terms of wound healing when it was started within the first 3 months. So their protocol is not to start mTOR inhibitors in the first 3 months post-transplant. You can subsequently put them on mTOR inhibitors after the first three months. And I'm sure that's also the same thing in your center as well, where you studied. But I personally don't have much data in terms of an experience in terms of starting it as first line immediately post-transplant. I don't know if Dr. Twari, you have anything to add?
No, I don't think it's a good idea to start everolimus soon after transplant. But again, the expert is already arrived on the stage.